Thank you. Wonderful to be here. It's an absolute honour to be given this opportunity, and thanks to Thorne Harbour Health for the invitation and the real privilege of being able to present today. I'd like to acknowledge that I'm on Bunurong country and to pay my respects to elders past, present and emerging. So I want to speak on discomfort today, and not just because it's a 30-degree day and I've come from a rather sweaty car, but because I think it's a really critical interface that has been part of my development, and I think it's part of the way that we all go through journeys with difficult conversations with others. I'm an ordinary guy who's been thrown into extraordinary circumstances through the COVID pandemic of the last 3 years. And I can't speak to, my development over that time. I'm not the best one to judge it, but I do think I've sat in discomfort a great deal over the last 3 years, sometimes some extraordinarily uncomfortable situations, not just in sitting down, trying to make decisions, trying to set policy, but toe-to-toe with people who exercise a significant amount of power, and sometimes toe-to-toe with people who have a very different view in a highly contested space. And these are not unique to COVID. There have been hugely controversial and contested spaces, especially for marginalised populations, especially for those who've had to struggle for their voice to be heard and for their rights to be exercised. My very first clinical work, or amongst my very first clinical work, was in 1993 when I was at the Fairfield Hospital. I was the most junior person on the ward. What a fantastic hospital. But some of my earliest experiences there were very memorable. And they speak to the way that your early clinical experiences speak to the frame and the system that you work in, but also to the individual conversations that you have and the way that they stick in your brain and make you cogitate for a long time afterwards about exactly what's at play there. One of my very first patients, and this was not typical for Fairfield, but it became a really entrenched memory in my mind, was a young HIV positive man. He was a sexual predator, so he was on a public health order, probably from the Chief Health Officer of the day. I don't know who that might have been, Graham Roach. And he was dying. He had just days to live. It was my job to take bloods on the ward every morning. And so I would go in to his room every day to take his bloods. And I remember the security guards who would sit by his bed because he was under 24-hour guard. Now, the guy couldn't get out of bed. He couldn't walk. And he literally had days to live. But again, the framing of HIV in that context was that he had 24/7 guard by his bedside to make sure that the community was kept safe. Now that has stuck in my mind. I reimagine it in the world that we live in now, but also reflect on the public health orders that still continue to occasionally occur through the Department of Health's response to individuals who put others at risk. It was also one of my earliest experiences of palliative care, and it was very unusual, again, in as much as there was a man in his early 30s who wanted to talk through with his clinicians how he could stop taking his medication, how he could allow himself to die. And I'd been involved in palliative care before, but I'd never been involved with someone who was such an advocate for himself and where his clinicians were advocating so strongly for his own well-being at a time when he was dying. And that had a profound effect on me because it was a strong voice in the last days of a man's life about the exercise of his own agency. And That played out a lot in Fairfield. The clinicians there were extraordinary. Obviously, we've lost the Fairfield, but I've also reflected on that issue of mainstreaming. It was a haven, especially for gay and bisexual men. They felt at home there. There were double beds on the wards for partners to stay over. They felt like the people who were looking after them understood them and understood their priorities in life and in dying. I think mainstreaming has been an important evolution in HIV care. Clearly, it's important that people with HIV can be looked after by their GPs in community health centres across the state, and you don't have to find this one specialist expert tertiary hospital to provide care. But I think we need to try and keep the essence of what Fairfield was able to provide at that time and what other services are able to provide, which is having that patient-centred, that community-centred view in everything that they do. And that's what Fairfield did so magnificently well. There were lots of uncomfortable conversations at the Fairfield, and I'm glad that I was part of them because it was a real part of my clinical development. It was a deeper understanding of the world, especially for HIV-positive gay and bisexual men in the 90s in Australia. I did see a video not that long ago of those early days in San Francisco, 1981, 82. And again, it reminds me of the uncomfortable nature of those conversations, but how critically important they were. And it was all of those, it was the mayor and all of those other San Francisco councillors on one side of a long trestle table, and gay men being told that the bathhouses were going to close in San Francisco. And it was a furious conversation. It was full of venom and vitriol, but it was an important conversation, and it reflected the time when gay and bisexual men knew what was going to happen. I mean, they were being told, oh, the epidemiology of this disease, it's spreading in gay and bisexual. They knew that. But what they also knew was that they were going to be the scapegoats for the actions of government at that time. And that continued for years and years and years, especially in the United States. And so their angry, defensive, but also passionate and community-focused riposte to that conversation was a really important one. And, you know, it was a totally undeveloped conversation. These were councillors who just didn't understand the community, didn't understand that what they were saying, how they were responding was not about the issue of the day. It was about the vilification, the marginalisation that had been practiced for generations and generations. And of course, it played out in America in a somewhat horribly unique way. Ronald Reagan, in his first term as president, didn't mention the word AIDS from 1980 to 1984, didn't mention the word. And so his discomfort played out, you know, in classic Freudian style. You've got transference or projection or denial. It was just pure denial, and it extended to all of those other things that made Ronald Reagan uncomfortable, including drugs. And so the shooting galleries in the United States at that same time, right at a time when harm reduction needed to be core to the public health response, was completely ignored. And so the corollary of that was that HIV in the United States spread from the gay and bisexual community in a much broader way than it did in other parts of the world. And so it came to women, it came to populations that it may not have at the same rate. And to this day, the United States suffers from an HIV prevalence that's, I think, 10 times higher than Australia's. That's a legacy of thousands of lives lost because of that denial, because Ronald Reagan couldn't get his head around a reality that everyone else could understand. And good on Australia, you know, we go through our stuttering progress on a lot of public health issues and coming to terms with various realities that make us feel uncomfortable. But our needle and syringe programs have been a cornerstone in the country for a long time. To this day, 42 years after HIV emerged in the United States, there's still legislation that outlaws the provision of clean needles to drug-using people in certain places in the US. It is extraordinary that 42 years later that would be the case. I'm not sure why it's so hard. I have my personal reflections. I think the United States is a bit of an example of a strange puritanical framing of itself, the frontier lands where they saw themselves in an overly idealised, highly libertarian fashion. It was all about what I can achieve for myself. And that sense of community, that sense of reaching out and doing what is good for everyone, especially those who cannot be served well by an individual pursuit of wealth or an individual pursuit of land. That has been a real feature of the United States. They also brought a really puritanical version of Christianity with them, and it continues to this day. Of course, the Western world suffers from it as a general malaise that Elizabethan sexual repression still hangs heavy over society. You wouldn't know it with a third of internet traffic being pornography, and with all of the things that we can access in our lives relatively freely in terms of our sexual proclivities. But the heteronormative approach that we have in the way that we see marriage, in the way that we frame normal and abnormal relationships, in the way that someone can still go out there and say, oh, it wasn't Adam and Steve, it was Adam and Eve, that stupid, pithy, attempted dismissal of a reality of someone's life speaks to how 17th century we still are in our conception of sexual relationships. I read a terrific book called Sex at Dawn. I don't know if anyone here has read it, probably. A terrific book that just speaks to the great panoply of sexual relationships. And it's not to say that monogamy is broken, but there is a huge myth of monogamy, that it's idealised and it's the way that frames everything else that we see in terms of marriage, in terms of relationships, in terms of fidelity. And they, you know, of course, they highlighted the fact that a third of all marriages have infidelity within them, and spoke to the great variety of sexual relationships as they occur in the real world. We don't see that and hear it and understand it in our day-to-day lives, and therefore the framing of public health issues that affects the LGBTQIA+ community is always through that lens. It's always through that's on the outside, that's on the margins, that's the difference, rather than that is the great rainbow that society is. We've got a long way to go in that regard. Of course, the conversations have been had. There's some re-engineering of the way that we talk about things, the way that we illustrate things, the way that we place the LGBTQIA+ community at the heart of policy making. But there is a long, long way to go just in the conception that we approach as human beings. Why is that important? Because I think policy journeys are personal journeys. And in the same way that Ronald Reagan was a Luddite laggard in the world of HIV in the 1980s, we still have individuals and collectively as organisations or departments being held back by not having gone on that personal journey of understanding, of depth of experience, regard to the way that these issues are multidimensional, they're personal, they relate to the most intrinsic features of our lives. We can't do that without having so-called uncomfortable conversations. And so I would come back to that issue of discomfort. And look, it exists within the debate today, with the department thinking about fully named identification for HIV notifications. We have that conversation, goes back and forth. It's not for me to make a call on, but it's for all of us to have the conversation about at the very least. And I need to understand how that resonates around the criminal prosecution of people with HIV, the public naming of individuals. But I hope that the community also understands that we think there is use of data that can bring wellbeing and health to populations in a way that we haven't been able to do with the current notification system. There are issues of HIV and criminal justice that are still to be resolved in my mind. I'm not speaking as a departmental policymaker here, this is Brett Sutton talking. There's a long list, I think, and it relates to the fact that there is still criminal prosecution for people with HIV who, sure, knowingly have sex with someone and therefore put them at risk of transmission. But we all come to a sexual relationship with an understanding that anything can happen, right? Anything can happen. That's why condoms are recommended. That's why pre and post-exposure prophylaxis and all the rest of it are something that we're made aware of so that we can come as sovereign beings into sexual relationships able to make a choice. Now, that's not a resolved issue, and there may well be lots of tricky situations to talk through about when you're in you're understood to be in a committed relationship or you've been married for many years, and the last thing you would expect is to be exposed to an infectious disease. But it's also absolutely relevant to talk about HIV because we're going into a time and place where HIV will not carry the mortality that transmission of hepatitis B to a sexual partner may carry. There are still people who cannot be cured with antivirals with hepatitis B who will have their life significantly shortened by hepatitis B. And so rather than moving hepatitis B into a criminal space, I think there needs to be a reimagining of what it means to have HIV and how the police might see that, or how the criminal justice system might see that. Keith Harbour was a legend for saying, talk to us, not about us. When I was in East Timor, 2008, 2010, we worked on a child health project that was framed in a very similar way, if I may say so, and it wasn't HIV related, but the signature block at the bottom of my email was with, through and for the Ministry of Health of Timor-Leste. And it's that partnership approach that says, this is not about me, this is about facilitating the will of the Ministry of Health in Timor-Leste. And I'm sure Keith Harbour was saying the same when he was saying, it is not just about even the very best service provision to people with HIV/AIDS, it is about a system of service provision that puts those people at the heart of that service so that it is appropriate, not more than appropriate, so that it is right and good and positive for all of the people who need that service. Not about me going, oh, we need a survey to understand what people think and need and blah, 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 and then me framing it, but really hearing those voices. And again, early on in that service provision for HIV/AIDS, it was very clear that there was a huge disconnect and a lot of uncomfortable conversations were had, but needed to be had, because advocacy is about bringing action for what you understand to be the proper play of justice in your life and in the lives of those around you, being responded to by those who hold the power and hold the levers for healthcare. So my call to you and my call to myself is, let us all sit in uncomfortable conversations together, but bring our passion, bring our advocacy, bring our open-mindedness. If we go in with a compassionate heart and a genuine willingness to hear and a genuine willingness to change, then the policy that will play out over time will work in all of our stead for all of the issues that are near and dear to us. I'm very happy to take questions, but thank you.